Walk backwards.
Or we'll have to stop there.
Okay.
Oh, we have to dim those lights.
So I just want to introduce you to one of the 17 participants that we spoke with in Rwanda. For obvious reasons, some reasons more obvious than others, we couldn't take photographs of refugees. I'm really concerned about representation issues and would really much rather see people be able to represent themselves when they're in situations of suffering, distress, or whatever. But even given our limitations, there wasn't a chance for us to invite refugees to represent themselves. But I still wanted to use photographs to, because there's details in a photograph that are hard to explain in words. And so to just show the youth and beauty of one of these participants. She was a 32-year-old mother of 4 elementary school children with breast cancer. She had surgery in October of 2017, and she went for her 3-month follow-up visit. It was clear. She then was going to go for her 6-month follow-up visit, and she had the appointment, and she went to the hospital, and they denied her to go see the doctor because her transfer papers weren't, they had lapsed. And so she had to go back to the clinic, hospital, the camp clinic, and reapply for a transfer to be able to go and get the appointment. And this, again, then took months of bureaucratic delays. And in the meantime, a new mass appeared, and she was very open in showing us how large this mass had become. And while she didn't want to talk about her own mortality, she was clearly thinking about this. Because when she was talking about what her largest preoccupations were while she was dealing with this illness, it was to see that her children would be looked after while she was still alive. Those were the words that she used. So for her, the biggest issues were her children to be looked after and to reduce these bureaucratic delays, which seem to have been causing the illness itself to become more of an emergency situation. So that is a brief little introduction to one of the many people that we spoke to. This is a case study on what we're calling protracted conflict in a refugee setting in Rwanda. It is a bit of a comparator to the Jordan case study. The Rwandan case, the setting is a bit more protracted. But we are doing even like another layer of comparison within this case study by comparing 2 different camps within Rwanda. So we visited the oldest camp in the country, which is from 1997. It has about 12,000 residents, mostly from the Congo. And then we also visited the newest camp, which is mainly Burundian refugees, and it's about 50,000.
Almost 60 now.
Almost 60,000 people living in that camp. And compared to Jordan, the Rwandan setting has lower socioeconomic status, lower health literacy, lower access to comprehensive care, and the people who are living in the camps in Rwanda are less used to having comprehensive care than Syrian refugees coming into Jordan from Syria. But one thing that's interesting is that Rwanda has had a national palliative care strategy since 2011, and for refugees, they're accessing that palliative care that's available to nationals, although there are still obviously limitations to what that palliative care looks like for Rwandan nationals.
Yeah, basically this is to show you the map of Rwanda. The Mahama camp is just here, and the Gihembe camp is above there. And maybe later on, when we'll be discussing about the routes to where there is the cancer clinic, is just there. So basically people have to go through Kigali, then go up there. It takes them, normally it's around 8 to 9 hours, but since they're refugees, the transportation has to be approved by UNHCR, then go to Kigali where the facilitation, they have to sleep over, then the following day they have to go there. And most of the time they reach the afternoon, there is no doctor, it's a rural area, so they have to sleep over again for the following morning to see the doctor and the treatment and everything. Yeah, so basically that was that. And we interviewed 10 people, where there were 3 female and 7 male. And also, main of the condition we only have leukemia was for among 3 patients, and the breast cancer was 2 patients. We had, this is multiple myeloma, I'm sorry, and there were also squamous cell carcinoma, erythrostenosis, mitral stenosis, and one lady who was having a blast injury from a bomb in Burundi. The main concern that they were having, maybe we can call it the primary findings, we just try to summarize. We also interviewed some health professionals. There were 5, and 1 in the officials from the camp officials too. And the main concern for the patient was mainly to reconnect with their family. They found it more a problem. And since back home they can't go back and see and call, and it wasn't easy for them to live alone, most of them. And also during his own health care, they were also concerned about their child, where they lived, especially the mother who was having breast cancer and some others. They were talking about how we will take care of those 3 days while I'm going to Butaro Hospital, the clinic, who will be staying with my children. It's always a concern. I have to do the neighbor, but the neighbor won't bother him all the time. And there were also problems and trying to know after my death who will be taking care of those children. The very same thing, they were also concerned about the problem within the camp. You know, the Mahama camp doesn't have any electricity, even though they promised them that they will put some. They have solar lamp, but it's not everyone who has it. It's only because in Mahama there is 2 parts. There is RC and there is also Save the Children. People from Save the Children are better taken care of. I can say they have more things rather than people from RC. It's always also difficult, especially at night or when it's too hot or something like that, to have a fan. And there were also the major concern about public knowledge, because they were perceiving healthcare professionals and the family and the community as if they are taking them as they are already dead. It's already a deal done, we can't do anything about them. So basically they were dead standing, dead living. So it's something which was bothering them too. Of course, the pain management and the administrative papers going, you know, first finding a transfer sheet, you go to HCR so they can approve that they will pay your treatment, then you go to Kigali where you will be staying, you know, all those kind of things take long. It takes months, like Sonya was explaining. Of course, among the healthcare professionals, they were mainly concerned about the public education or psychoeducation on life-threatening conditions, terminal illness and cancer, for people to know and also for them too how to deal with those kind of situations. And they were saying it's a pity for them. They can't really bypass the triage. It takes long because there are like 100 people in the morning. A patient who was in terminal illness have to wait until his turn arrives. So they were proposing if there is any way they can have a special clinic for them where they can just bypass all the triage and have a specific group in charge of chronic illnesses and including the palliative care unit. That would be helpful for them within the camp. And also, for sure, the palliative care will have to be integrated in different health disciplines, within the camp, like is what they were saying. I think maybe the remaining will be, yes, the distance, I talked about it already, and the bureaucracy on the map when I was explaining. The rest maybe she can.
And this is our last slide. So there's another one of the participants that we spoke with, and it was actually her son who was had a terminal cancer illness, and he was bedridden and couldn't speak, so she spoke on his behalf and provided her perspectives as being a mother of 7 children with 1 child who was in the men's ward at the camp clinic. But one thing that the healthcare providers that we spoke to really kept on referring back to over and over again was the sense of accompagnement, being there. At the very minimum, having, whether it's a healthcare provider, family members, or even community volunteers, being with people who are very, very ill or dying. So in the Mahama camp, one of the healthcare providers had started a Good Samaritans program with refugees volunteering to go and visit with terminally ill people. So there's like at the bedside accompagnement, but also in terms of advocacy. And a lot of the healthcare providers were also accompanying these individuals to help them try and find access to pain medication, to even just certain material goods, like getting a mattress or the lights or fans and so on, so that they can cope with their pain and make their situation as good as possible. So there we go. Thank you.
Just, you didn't explain that those are composite photographs. They're not, they're not the actual photos taken up to part. They're actually just
Composite photographs of how I remember, like really I made these right after we did the interviews, and it's based on my recollection, down to what kind of clothing the people were wearing, trying to find the similar facial features and so on to try and convey the individuals that we spoke with.
Thank you.
I wonder, I have a